Hello folks, I am Dr. Kofi and welcome to my YouTube channel, TutorMed, and here, everything medicine is simplified. And so as promised, this video will begin a lecture series which will cover basic ECG interpretation. And so if you want to understand the ECG and its interpretation, you might want to consider subscribing and more importantly, put us on post notification by hitting the notification bell beside the subscribe button so that you can be notified anytime we upload new videos. And also please do not forget to like and share this video and leave your comments in the comment section below. Without wasting my time, let's begin. Well folks, I am not an authority in medicine. However, it is my opinion that when learning the ECG, one should not jump straight to the ECG paper wanting to eagerly interpret it when there is little or no understanding of its principles, as this leads to chewing and pouring. On that note, let's begin with the first principles. As you may know, the heart muscle or myocardium contracts automatically to move or circulate blood through the body. Before these automatic contractions can occur, electrical currents or impulses have to move through the myocardium to activate it. In other words, no electric currents to activate the myocardium, no automatic contractions. And so how do we evaluate this electrical activity within the heart or the myocardium in clinical practice? We use the ECG, which stands for the electrocardiogram. And so the ECG gives us a graphical representation of this electrical activity as the currents or impulses journey through the walls of the heart or the myocardium to bring about contraction and relaxation. And as we will see later, the word graphical in this definition means that the ECG has a y-axis and an x-axis. And so let's look at the electrical system which produces and conducts the electric currents to the chambers of the heart to bring about automatic contractions. This diagram on our left illustrates that. Briefly, let's review the chambers of the heart. We have the right atrium, the right ventricle, the left atrium, and then the left ventricle. The green pathway in the diagram represents the heart's electrical system. And so in the superior part of the right atrium, we have the sinoatrial node or the SA node. This structure is the pacemaker of the heart, and this means that for the normal and healthy individual, this node is the source of the heart's electrical impulses, and it is the SA node which determines the rhythm and the speed at which the heart should beat, hence the name pacemaker. Next, we have the atrioventricular node or the AV node, and we will see its function in a minute. But as you can see, there are connections between the SA node and the AV node, and these connections are called internodal pathways or fibers. That is, fibers which are between two nodes, hence the name internodal. And also note that there is a connection with the left atrium via this fiber known as the Bachmann's bundle. The connections with the right atrium are not well defined like the left atrium, and so are not shown here. But here is the point that when the SA node produces the current, the right atrium gets them first, obviously because of its position, followed by the AV node and the left atrium. However, the time difference is so negligible that the left and right atria contracts almost simultaneously. Now, the AV node is there to delay the impulses received from reaching the ventricles at the same time the atria are contracting. Otherwise, the atria and the ventricles will contract at the same time and there will be chaos in the heart. Good. And so after delaying the impulses sufficiently, the AV node gives the impulses to this structure here called the bundle of His, which transports the impulses to the two ventricles. Now to achieve that, the bundle of His divides into the right bundle and the left bundle branch. And although this is not shown in the diagram, the left bundle branch divides into an anterior and a posterior fascicle. Both the right and left bundle branches end in small fibers called Purkinje fibers, which gives the impulses finally to the ventricles. And so to summarize this in a schematic diagram, this is the SA node, which has three connections with three structures. 1. Connections to the right atrium, then to the AV node, and to the left atrium. And when the SA node fires, all three structures get the impulses almost at the same time, but the first structure to feel the impulse is the right atrium. Then the AV node delays the impulses a bit and gives it to the bundle of His to begin the ventricular transport journey. The bundle of His divides into the right bundle branch and the left bundle branch, while the left bundle branch divides into an anterior fascicle and a posterior fascicle. The right bundle branch feeds the right ventricle, and the left bundle branch feeds the left ventricle, all through the Purkinje fibers. Very good. And so the SA node fires and the electrical impulses move through the chambers of the heart as well as the conduction pathway. What will the ECG show us regarding these events? Let's use this hypothetical diagram to illustrate this. Now this is a sample ECG paper, and this is a typical ECG tracing or recording of the electrical activity within the heart. This flat or straight line is called the baseline, and the deflections above and below the baseline are called waves. Basically and simply put, a wave is formed when a deflection leaves the baseline and then returns to the baseline. Any deflection above the baseline is a positive wave, whilst deflections below the baseline are negative waves. For example, this is a wave because there is a deflection from the baseline and it returned to the baseline. And more importantly, it is a positive wave because the deflection was above the baseline. And this here is a negative wave because there was a deflection which returned to the baseline, and that deflection was below the baseline. When naming the waves on the ECG, the fathers of ECG for no reason chose the letters P, Q, R, S, T, and U, and so there is no reason to understand why A, B, C, D, E were not chosen. These letters were chosen arbitrarily. And so the first positive deflection on the ECG is called the P wave. And this wave represents the point at which the right and left atria are activated by the currents from the SA node. This activation is properly termed as atrial depolarization. And atrial depolarization is responsible for atrial contraction, automatic contraction of the atrium or the atria. Now, after the atria have been activated, or properly termed depolarized, it makes sense that they should be deactivated, right? Because the currents cannot run through them forever. Their activation or their deactivation is called atrial repolarization. Please hold on to this. We will revisit it later. Now, after the atrial depolarization has occurred, there is a period of silence represented by this line until the impulses reach the ventricles. And so what do you think this period of silence represents? Yes, you guessed right. This is the point when the AV node is delaying the impulses. After the delay, The impulses reach the ventricles and activate them, and ventricular activation, or properly ventricular depolarization, is represented by these deflections, a combination of the Q, R, and S waves. And because they are a combination of waves, this is called the QRS complex. And so the QRS complex represents ventricular depolarization. We will explain why for the ventricles the ECG gave us a complex, but for the atria the ECG gave us a wave. But follow closely. The atrial repolarization, which is its deactivation, occurs at the time of ventricular depolarization. But where is that event on the ECG? The ECG did not record it. Why? Because the ECG is a paparazzi. It only takes note of big events, and so to the ECG, ventricular depolarization is more important than a small atria deactivating, and so it will record the bigger events. After being depolarized, it will take some time to be deactivated, and that time is represented by this moment of silence here. After the moment of silence, the ventricles will repolarize, and then the repolarization gives this positive wave, and it's called the T wave. And so the T wave represents ventricular repolarization. Very good. And so how is the ECG machine used to generate the readings of the heart's electrical activity? To answer this question, we need to understand two terms: electrodes and leads. Now, when doing an ECG for a patient, we put some parts on the patient's limbs and some on the patient's chest, and these parts are able to record the heart's electrical impulses. The parts we put on the patient's body are called electrodes. The electrodes we put on the limbs are called limb electrodes, and those on the chest are called chest electrodes. The part of the chest occupied by the heart is also called the precordium, and so sometimes the chest electrodes are known as precordial electrodes. Then we come to what a lead is. Now, the ECG machine analyzes the electrical activity of two electrodes typically and draws it as a graph. This graph is what we call an ECG lead. And so in a nutshell, all we want to say is that leads are generated by the machine when the machine analyzes the readings of the electrodes we put on the patient's body. As an example, which we will see in a minute, we will learn that there is a lead called lead 1. And that lead was generated when the ECG machine analyzed the readings from the electrodes or parts which were put on the left arm and the right arm. Alright, now let's practicalize the concept of electrodes and leads. And so we have this patient we need to do an ECG for. What we need first is to put electrodes on him, but the question is, which part of the body should we put these electrodes? A man named Willem Einthoven gave us the first ever idea on where to put these electrodes. He proposed we used the limbs of our patient, and there are 4 of them, isn't it? And so he said we should put one on the right arm, then another on the left arm, and then one on the left leg, and another on the right leg. Now the part we've put on the right leg is actually a neutral part, unlike the 3 others. That part is unable to record electrical activity, but the previous 3 are able to record electrical activity. Now, if we join these 3 electrodes with lines, which figure do we create? A triangle, you are right. And actually, per his calculations, Einthoven showed that this triangle generated is an equilateral triangle, meaning each of its internal angles is 60 degrees. And so this triangle was named Einthoven's triangle. Is this triangle important for us to know? Yes, and we will see that in a minute. And so on the Einthoven's triangle, let's put the right arm electrode here and the left arm electrode there. And let's put the left leg electrode here. Now, let's simplify this without going into the electrophysics so that we can be clear in our minds. Remember, we said that the machine itself analyzes 2 electrodes at least and produces a lead? Yes, you remember. And so when the machine analyzes the right arm electrode and the left leg electrode, the lead it produces is called lead 1. Then, when it analyzes the right arm electrode and the left leg electrode, it produces lead 2. And we have lead 3 when the machine analyzes the left arm electrode and the left leg electrode. Now, with this principle clear and backed, let's move to the significance of leads. Again, we want to simplify this concept without going into the electrophysics. And so this is the heart, and we want to know its electrical activity, right? Now, draw your 4 cardinal points, the horizontal line and the vertical line. Now, on the Einthoven's triangle, look at the direction of lead 1. You see it's horizontal, and so we will put lead 1 here. Now, do you see lead 2's direction? Put lead 2 here, and it makes sense that lead 2 should be there because of its position on the Einthoven's triangle. And then put lead 3 here because look at the direction of lead 3 on the Einthoven's triangle. Now, on the cardinal points with the heart, do you see the leads are looking at certain sides of the heart? For example, leads 2 and 3 are looking at the inferior wall or surface of the heart. And so, the significance is that if we want to know, for example, if there is an inferior MI, we look at lead 2 and 3. And it appears lead 1 was looking at the lateral surface of the heart on the left. But there was a problem because Einthoven's model gave us only 3 views of the heart. Now, if 3 people were to report on the features of an elephant, one standing in front of the elephant and the other at the back of the elephant, and a third person on the side of the elephant, you would agree with me that it's a huge problem because we won't get the top features and the under surface of the elephant because we only have 3 views. That is the same problem Einthoven's model posed. Alright, and so the medical community realized we will miss a lot of information on the heart's electrical activity if we used only 3 views or 3 leads to evaluate the heart. Just like 3 people would record an inadequate information on the features of an elephant only because they were few in number. And so there was a need to increase the number of views around the heart. And so to understand how this was achieved, let's bring Einthoven's triangle here because that was the basis for the increment. And then put the 3 limb electrodes here. The right arm electrode, left arm electrode, and then the left leg electrode. Now, to increase the number of views, 2 guys, Wilson and then Goldberger, stood up and said, look, let's add the electrodes on the right arm, and then left leg. If we do that, we will form a central terminal here, and that electrode is virtual. It means it is not real, but it was produced when we added the 3 arm electrodes. That central terminal or that central electrode was eventually called Wilson's central terminal. And so with that electrode in place, it means the machine can now analyze the limb electrodes against this central terminal. And so when the machine analyzed the left arm electrode and then the central terminal, it gave a lead called AVL. AV means augmented voltage, and so AVL means augmented voltage on the left. And when the machine analyzed the right arm electrode and then the central terminal, it gave a lead called AVR, augmented voltage on the right. And then the left leg electrode and then the central terminal gave another lead called AVF, augmented voltage on the foot. Now watch the direction of each of these new leads. I'm sure you can position them on the cardinal point system and even tell which side of the heart they look at, right? We will see this soon, but please note that the augmented voltage is so named because the machine has been programmed to augment the readings of these leads so that they can be conspicuous enough to read. And so, putting all these together, it means we have 6 limb leads. The ones generated by Einthoven are called standard leads. And so we have leads 1, 2, and 3. And the ones generated by these two gentlemen are called augmented leads, AVL, AVF, and AVR. Very good. And so on this slide, we want to position all the 6 limb leads around the heart. And we always start with whose triangle? Einthoven's triangle. And so we put our left arm electrode here, the right arm electrode there, and the left leg electrode here. And so we saw that the ECG machine generated lead 1 here, lead 2 there, and lead 3 here. And with the help or thanks to Wilson and then Goldberger, we were able to generate this virtual central terminal called Wilson Central Terminal. And so once it was there, the ECG machine was able to generate 3 more leads, isn't it? We have AVL here, AVR there, and then the AVF here. And so to position this around the heart, we draw the heart anyhow we want it, and then draw our cardinal points, a horizontal line and a vertical line. Now, look at lead 1 again. It is horizontal and the direction, so we put lead 1 here. Look at lead 2, we put lead 2 here. It makes sense because that's the direction. And look at lead 3, it's in that direction, and so we put lead 3 here. And then look at the the augmented leads. Their shape even tells you where they should be, right? So AVL, it makes sense it should be on the top, on the left, so in that direction. And then AVR on the top, on the right, so in that direction. And look at AVF, directly 90 degrees, and so AVF should be there. Now, this system of 6 limb leads is called the hexaxial system. And then from here, you can understand why we say leads 2, AVF, and lead 3 are inferior leads, isn't it? And then you can understand why we say AVL and then lead 1, look at the lateral surface of the heart on the left. Very good. Again, there was a problem because 6 leads means we are viewing the heart in only 6 positions. And if you realize, the limb leads look at the inferior surface and then some part of the lateral surface. And this plane is known as the frontal plane. But how do we know what is happening, for example, in the anterior surface of the heart? The limb leads do not tell us that. This is where the chest electrodes are very important. And so let's look at the positionings of these chest electrodes. The first chest electrode is put in the 4th intercostal space on the right, near the sternum, and this is known as the right parasternal region. The second electrode is put at the same level, but this time on the left, so the left parasternal region in the 4th intercostal space. Then we skip the 3rd and we move to the 4th electrode. And so for the 4th, we put it in the 5th intercostal space mid-clavicular line on the left. And this location also happens to be the location of a normally placed apex. After we've placed the 4th electrode, we put the 3rd electrode in between the 2nd and the 4th electrodes. Now medically, the armpit of the patient is known as the axilla. And so we put the 5th electrode on the anterior axillary line in the 5th intercostal space on the left. And then the 6th electrode in the mid-axillary line, also in the 5th intercostal space on the left. Now this diagram appears as though the 6th electrode is put on the arm, but actually it's in the mid-axillary line. And so 6 electrodes on the chest, but we are interested in leads, not electrodes. And so how does the machine generate the leads from the chest electrodes? To understand that, let's assume this is the cross-section of our patient's chest. And so we position the first chest electrode, 2nd and 3rd, 4th, 5th, and 6th, as we discussed. Now, What electrodes will the ECG machine analyze to produce the chest leads? Will it analyze V1 and V2 together, or maybe V3 and V4 together? No. It goes back to its friend, the Wilson's central terminal. And so, when the ECG machine analyzes the first electrode and then the Wilson's central terminal, we have V1. Then the second electrode and the central terminal, V2. Then the third electrode, central terminal, V3. Then the fourth electrode, the central terminal, V4. The fifth electrode and the central terminal, V5. And then the sixth electrode and the central terminal, V6. And so in all, we have 6 limb leads and then 6 chest leads. And then these 12 leads constitute what we call the standard 12 lead ECG. And so for an ECG to be standard, it has to be made up of these 12 leads. But remember that some people can generate more leads by putting electrodes at the back of the patient. And so we want to indicate the part of the heart each of these leads monitor or evaluate. And to do that, let's draw the spatial arrangement of the leads again, beginning with the limb leads. And so we have our vertical line and our horizontal line. Lead 1 is here and AVF is there. Then we have this line for AVL and that line for AVR. And then we have lead 2 here and this line for lead 3. That is for the limb leads. Now on the chest leads, let's draw our cross section and then put these guys there. We have the central terminal there, the first chest electrode, second chest electrode, third chest electrode, fourth, fifth, and sixth. And so we have V1, V2, V3, V4, V5, and then V6. Please note that this drawing is not that accurate, but at least it gives us an idea of the position of the leads in relation to the heart. And so based on these drawings, V1 and V2 are said to be septal leads. They give us information about the electrical activity in the septum. And V1, by virtue of its position, also tells us a lot about the right ventricle. The anterior leads are V3 and V4. Now, in my previous videos, remember I mentioned that a few literature consider V2 also as an anterior lead. But please understand that majority of the reviewed literature consider V1 and V2 septal leads and then V3, V4 anterior leads. Then, again, based on the drawing, we know that the inferior leads are lead 2, AVF, and then lead 3. And then, for the lateral leads, now the lateral wall of the heart has a higher part and a lower part. And then from the diagram, AVL and then lead 1 brings information from the higher part of the lateral wall, and so are called high lateral leads. And then V5, V6 are called lower lateral leads. And so together they constitute the lateral leads. Remember that although AVR also looks at the right lateral wall, it is not part of any group. But we should note that it brings information from the right atrium and then the sinoatrial node by virtue of its position. Alright guys, please do not forget to like and share our video and subscribe to our channel if you have not done that yet. And more importantly, don't forget to put us on post notifications so that you can be updated on our newly released video. And then kindly leave your thoughts about this video in the comment section. Now, it seems we have spent so much time understanding the basic principles, but please understand that without them, the ECG won't make much sense. I hope you understand that whenever you pick the standard 12 lead ECG, you are looking at information regarding the electrical activity of the heart from 12 different points of view. Because the leads are at different points, they see things differently, but it is the same story they are telling. As an example, imagine a car moving from point A to point B, and say Henry is standing at point A and Sandra at point B. Both of them will see the car moving, but Henry reports the event as the car moving away from him, while to Sandra, the car is moving towards her. but both of them are telling the same story, a moving car. This is same with the ECG leads. They all describe the same event: atrial depolarization for P wave, QRS complex for ventricular depolarization, and then T wave for ventricular repolarization. But they do it differently because of their positions. And so these two diagrams illustrate this. The first represents information from the limb leads, and the second, information from the chest or precordial leads. Notice that the pictures they are painting are different. Okay, so they are different because of how each of them see the direction of the electrical impulses as they spread from the SA node downwards to the ventricles. And so the general rule is that whenever a lead sees electrical impulses come towards it, it reports a positive deflection. And whenever it sees the current moving away from it, it records a negative wave. To demonstrate this, let's pick these two leads. Look at AVR and then lead 2. Now, we said in the early parts of the video that the P wave is the first positive wave in the ECG tracing. We said it was positive because on that tracing we were discussing, it was positive, and we did not want to make things complex at the very beginning of the video. But strictly speaking, it is the first wave, regardless of whether it is positive or negative, on the ECG before the QRS complex. Now look at the P wave in AVR. It is negative, but in lead 2, it is positive. Why? Because when the SA node fires and the current gets to the atria to depolarize it, the currents move away to the ventricle. So to lead AVR, it is moving away. That is why the P wave is negative. And then to lead 2, the current is coming towards it. That is why it records positive. And then this is the same for QRS complex. You see that the QRS complex is negative in lead AVR, but positive in lead 2. It is the same principle. And so please understand these basic principles, as they will help explain the shapes of the QRS complexes later in our subsequent videos. And so on this slide, let's look at some other features of the ECG tracing. This is one cardiac cycle, and this is another. We looked at the P wave, the QRS complex, and then the T wave, and we looked at what each of these represent. Now we will look at two other concepts: the segments and intervals. A segment is a line between two waves. So for instance, a line between the P and the Q waves is called the PR segment. Wait, why not the PQ segment? Some of you may ask. Well, I did not find any explanation for that in literature, but I'm guessing that the Q wave is not present in all leads, as we will see later. That is why probably the 10 PR segment was chosen. Then the line between the S and T waves is the ST segment, a very popular one. Then the line between the T wave and the next P wave is called the TP segment. Now to intervals. Once there is a wave included, then it is no more a segment but an interval. For example, a P wave plus the PR segment is a PR interval. Or better still, the beginning of the P wave to the beginning of the Q wave is called a PR interval. And this interval has a diagnostic value, as we will look at later. Then, from the beginning of the Q wave to the end of the T wave is known as the QT interval. It also has a diagnostic value. So kindly note that aside the P wave, the QRS complex, and then the T wave, there are 3 segments and then 2 intervals. We can have an interval called RR interval, but we will look at that later when we are calculating the rate of the heart. Now, sometimes right after the T wave, there is another deflection called the U wave, which is thought to represent depolarization of the papillary muscles within the ventricles. Now, the papillary muscles are muscles which hold the cords which keep the valves in check. But we will not dwell so much on the U wave because it is not usually or always present, and so we will not dwell so much on it. Now, you remember we defined a wave based on the deflection from the baseline. The question is, what is the baseline? Now, you see all the three segments are on the baseline, and so which among the three should we use as the baseline? A good baseline is one which is not affected by disease conditions, and so among the three, the best is the TP segment. It is not affected by heart conditions or disease conditions. And as you may know, the ST segment changes when there is myocardial ischemia. And so if you want to know whether there is ST depression or elevation, compare it to the TP segment, whether it's the same or it's above or below it. And then although some literature recommend that the PR segment can be an alternative when we are using a baseline, you will find out that pericarditis can cause PR segment depression. And so compared to the TP segment is a good baseline indicator. Now let's look at the interpretation steps for an ECG. And this slide would end the session on the basic principles of ECG. There are a lot of interpretation steps proposed by different literature, but we will adopt the approach as proposed by UpToDate. The reason why I like this approach is that it analyzes the ECG in a stepwise and, more importantly, in a thorough manner. And so the first step is to check the name of the patient, the age, and then the sex, and the date on which the ECG was done. Next, check the calibration of the ECG machine to ensure that it has a standard calibration. We will see how to look at this when we begin the interpretation video. Then the next, you check the rate of the heart, followed by the rhythm of the heart. Then next, you check the axis of the heart. And the axis, you mean the ventricular axis or the QRS axis. Don't worry, we will explain this into details in our subsequent videos. Then after checking the rate rhythm axis, then you interpret the ECG based on what you see. And so you begin with the waves. And so you analyze the P wave, the QRS complex, and the T wave. Careful analysis of these waves will tell you a lot of things, including atrial fibrillation, atrial hypertrophy, ventricular hypertrophy, left ventricular hypertrophy, right ventricular hypertrophy. It can tell you ventricular rhythm, can tell you a whole lot of things. Then next, you look at the intervals. So for the intervals, you are looking at the PR interval, the QR interval. The PR interval, if prolonged, can tell you that there is a heart block maybe. Then we have, from the intervals, you move to the segments. And the segments, you want to look at the ST segment predominantly. It can tell you whether there is a myocardial ischemia or not. Then after that, you give your overall impression of the ECG. And so thank you for following through or following the lecture through till this point. And then our subsequent videos will address how to interpret the ECG with various conditions. So please stay tuned, and again, don't forget to like and share our video, subscribe to our channel, and then leave your comments in the comment section. Bye.